follow-up to ask you. You have deployed already some teams to different countries. How long they will be there, and how long you will keep your team in Mexico?
That's a good question. This being a marathon, as I mentioned, transference of skills, of technology, I think is a guiding principle in all this collaboration. So when the teams reach a point where they feel they have adequately trained the local staff, the staff is equipped with the proper reagents and materials, then there will be time for us to leave, because the national authorities and local conditions can take care of the situation.
You also mentioned that in some of the 26 countries affected by this virus, some hospitals and medical facilities are stressed. Do you have any concerns, specific concerns, that maybe some specific countries with poor resources are going to be more vulnerable to that?
So far, in general, we've been very lucky, but we've seen some isolated occurrences that could be, hopefully, will not be a predictor of what's to come. In communities with vulnerable populations, say indigenous people, we know that there are higher rates of chronic disease. And in some cases, we have seen that there appear to be more severe infections for the reasons I mentioned, and that the local health system has to mobilize additional resources. We saw this in the indigenous community of northern Canada, and certain supplies had to be moved in, such as additional respirators and such. So we hope, we want to maintain a very high level of monitoring and vigilance, and look to other communities of risk, particularly in the south at the moment, and be sure that we're adequately prepared.
Well, I just would like to add one more. I understand U.S. is leading a global effort to control the pandemics. Can you tell us, we understand some of the Latin American countries were included as part of this plan. Can you tell us who they are and what type of exercises or maneuvers they will be taking to control that situation?
Yes, there is a global response team. I'm looking at my notes to get the name correct. It's the Global Outbreak and Response Network. The U.S. Centers for Disease Control is a part of that, as well as the Public Health Canada and other countries such as Spain, Portugal, and other agencies that have a group of experts that can participate on teams that go to countries. And some of the countries that have already been visited include Mexico, Guatemala, El Salvador, Honduras, Nicaragua, Panama, Bolivia, Paraguay, and Chile. And there are plans in the next few days for the teams to visit Ecuador and Uruguay as well. So that has been mobilized. It's a team effort coordinated by PAHO with U.S. participating.
Okay.
Thank you, Dr. Andrus. We now have a question from Brenda Focas at Diario Perfil in Argentina, who says, I would like to know, how was the experience in the U.S. with schools closing because of influenza A? In other words, was it a helpful measure? Is it something we recommend?
It's a great question, and it really relies on the local conditions. If the local conditions reflect a situation where, particularly early on in the outbreak, you're just seeing a few cases limited to one school, perhaps school closure would be one way to slow the transmission down and help keep the health system from being overwhelmed with a relatively steep surge of cases. So we know that there are some studies to evaluate these interventions, but when decisions are made where the local health conditions don't support school closures, then we know we have learned from that as well. In some cases where transmission is at a higher level, there are more cases, there may be even some community spread. by closing the school, you're actually pushing and placing pressure on families. Families have to stay home from work. That may be a loss of income. So all those things need to be balanced.
Thanks, Dr. Andrus. And now Nelly Castillo from El Salvador asks, do we recommend continuing with laboratory analysis of H1N1, or now that we are in phase 6, is it sufficient just to use medical evaluation to determine the cases?
That's a great question. It's a great question, and early on in the outbreak, generally the approach has been what we call a case-based approach, where you try to identify every infection. But as you see more cases, and particularly as the capacity of the system gets taxed, then it's wise to back off on trying to identify every case. And that's why the surveillance that's been developed, it relies on a sentinel approach, where you can still collect information, collect specimens, and follow particularly the molecular aspects of the virus over time, and yet not stress the system from trying to identify every case, and more importantly, divert the attention needed to effectively treat the illnesses, the sick people, with high-quality health care. I think putting an emphasis on treating the sick would be most appropriate and the best priority at that point.
Okay, thanks, Dr. Andrus. Excuse me. Margarita Vega from Reforma in Mexico asks, how many resources or how much funding does the rotating fund have? How would it be distributed? And can Mexico have access or get access to those resources to buy vaccines against influenza A, H1N1?
The revolving fund has a fund of resources that we use to purchase vaccines for countries who cannot purchase or pay for them in advance. There's really two mechanisms, that group of countries, and then there's another group of countries, particularly larger group of countries, that can pay for the vaccines in advance and then not tax our fund. So we still maintain a fund that particularly supports the smaller countries or countries with less resources. So there's a balance there. But at the end of the day, all efforts to use the fund and maximize its use really adds benefit to all communities of the region, because we have this power of bulk purchasing to negotiate a more affordable price for all the countries, and an opportunity to serve all communities of poverty regardless of where they lived, as I mentioned in the presentation. Mexico traditionally has purchased its own vaccines, as does Canada and the US and Chile, and one other country. There's only 5 countries, I believe it's a country in the Caribbean. There's only 5 countries that do not use the revolving fund. So we have about 37, 38 countries that use the fund, and imagine that power when you combine the demand from all those countries to negotiate a more affordable price for everybody.
Okay, thanks. And we have a closely related question from Celia Carvajal, the Agencia Telam in Argentina, who says, are we placing emphasis on equity in distribution of vaccines because we consider that there will be a risk in negotiating prices with laboratories, or there will be some other type of economic limits?
Well, that's a great question, and it has different aspects. I think from a traditional level, a guiding principle that PAHO has had since its inception in 1902 has been equity, and that is to ensure that everyone has the opportunity and the potential to live a healthy life through medications, through vaccines when they're available and such. And so that's been a guiding principle. We have learned since to support this, that when you have healthy populations, you will have a much greater likelihood of having a healthier economy, more productivity. We used to think that richer countries have healthy populations because they're rich, but the reverse is true. When you have a healthy population, your country will benefit, its national economy will benefit. So there are different angles to the response to that question, but I think all lead to the bottom line, that equity not only is right for good reasons, but it's also proven to be shown to help the country prosper, as well as keep families healthy and together.
Says, I was just wondering if this new phase 6 is going to change the approach to this new virus in Mexico and in all of Latin America, and what kinds of new measures are the countries going to take?
I think it's a great question, and I think that for the last 40 days or so, we've been operating under emergency conditions. The personnel here at PAHO has been incredibly taxed to work day and night, weekends, to respond to this. I think the declaration of phase 6 allows us to take a step back. The interventions have been ongoing and appropriate for either a phase 5 or phase 6 level, and that's why I always say we have been operating under phase 6 conditions. But what it does in going from phase 5 to 6, it allows us to reflect on the fact we cannot continue sprinting, that this is a marathon. You know, most pandemics last years. So we need to get back to the basics, monitoring this virus, as I mentioned, treating the sick, getting the right communication messages out, having appropriate capacity, and doing this with a vision of over time. And I think that is a very healthy response, and I think most countries are doing that.
Okay, thanks. And she has another question from El Universal, which is in general about the new vaccine. When can we expect a new vaccine against AH1N1, and what will be our guidance to health ministers with respect to this new vaccine?
That's an excellent question, and we've been holding with our colleagues around the world, up until recently it was a daily conference call on the vaccine situation. It's now 3 times a week. Today we had the most recent call. So we are getting real-time, day-to-day information on the development and supply of this new vaccine, with several manufacturers involved in producing it. I think the best estimates that we have, and it's all very dependent on the capacity and the technology that each manufacturer uses, but it appears that vaccine will be ready to be used in the field probably sometime in mid-late September, October. In some situations, however, when you look at the conditions of a certain manufacturer, they will need to do clinical trials for a number of complex reasons that I won't go into. And doing those clinical field trials requires more time, and then that would delay the availability of the vaccine probably until the end of the year rather than earlier, such as October, as I mentioned. I think that another part of this that the questioner raised that's very, very important, who do we vaccinate? And that's another ongoing piece of the work that's being undertaken by PAHO and WHO. There's another group, it's a subgroup of the Strategic Advisory Group of Experts called our SAGE, that has been convening a subgroup of that group to discuss the current situation with the vaccine. Today they had a meeting and they reviewed all the data. They reviewed the data gaps. They're looking to convene an official meeting on July 7th in Geneva. And at that time, they will have more information where they can be better positioned to make specific recommendations, what age groups to vaccinate, what people at risk, who should we be targeting, those kinds of questions. There are other issues too. Most likely the vaccine will require 2 doses. That's the preliminary information, but there may be new data to suggest otherwise. These are some of the questions that this group will be addressing and will be very important for the global response.
Thanks, Dr. Andrus. And now we have a question from Paris, France, from David Zavaglia, a journalist for the French TV channel Arte. He says, I would like to know more specifically, how will Chile deal with the pandemic, since the number of cases there is much higher than other countries? Did Chile already choose to go into phase 6? And do they have the scientific infrastructure to analyze virus samples?
That's a great question. We saw a fairly rapid increase in cases in Chile. One of the primary reasons we saw that was different from other countries was that the first cases occurred in the private sector and private schools. And so there was a great demand in the private health sector for testing. And as I learned yesterday, of the more than 1,500 cases, probably about 1,000 of them were from the private sector, whereas in other countries, the usual situation is that cases come from the Ministry of Health laboratory network, the public health laboratory network. So that was a little bit different. And I would say that Chile has probably one of the better public health infrastructures and level of scientific expertise as any country in the world. They have very high levels of coverage. They have, I'll cite a specific example where in many countries, rotavirus vaccine, which would tackle a component of diarrhea in children and prevent deaths, because of the advances of sanitation and hygiene in Chile, that vaccine was determined based on a very sophisticated analysis, determined not to be cost effective or as useful. So just as an example to highlight the progress there. They also have very good cervical cancer screening programs. This is information that I know of. So that's my response.
Okay. Thanks. We've answered all the questions that came in by chat. Oh, but David Zavaglia asks a follow-up question. Did Chile specifically choose to go into phase 6? But I don't think that's a national.
No, the categories of the alert is really a normative function of WHO. Dr. Chan being the director, working with International Health Regulation Emergency Committee and all the consultations that she and her team has had. That's really a normative function at the global level and takes into account the data coming from all the countries. But it is not something that in most cases, something that the national level would do.
Okay, so we have no phone questions, I take it. We've answered all the email questions. Are there any additional questions from people in the room?
I would like to ask you about Mexico, Doctor.
Press your button.
After Mexico suffered the first cases, and now it seems to be controlled, after that, is it possible that we can see a new rise of cases and maybe deaths? And also, have you discovered which was the main reason that made this virus more lethal in Mexico than in some other countries?
That's a great question. Both questions are very good. And in response to the first question, most pandemics come in waves. So in the case of Mexico, it really behooves the National Ministry of Health and all the state Ministry of Health to monitor the situation closely as we are advising, because although we say this virus is predictable in its unpredictability. If we look at other pandemics, they do come in waves, and sometimes the second wave is actually the most severe wave. In addition to that, the virus comes back in some cases fairly frequently during the regular seasonal influenza. So the virus ends up replacing some of the seasonal influenza viruses that we would see otherwise. So it's something that, like I said, it's a marathon, and that marathon involves the monitoring and how the situation evolves. The second question was,
why in Mexico was more difficult?
yeah, I think that as the outbreak evolved in Mexico, the initial response by the Ministry of Health, for very good reasons, was to try to determine what was going on with patients who presented with severe illness. So they focused their resources and their priorities for investigating those severe cases. But it led to an understanding that I think needed to evolve over time. That preliminary understanding of severity was biased based on that initial response. So as that denominator, the total number of infections, is better determined, it's never perfect, but as we get more resolution, because the disease presents in different levels of severity, we now know that some people have very mild, some people almost no symptoms, whereas on the other end of this spectrum you have death. So it's quite a variability in presentation. And as we get to know that better, then you can put the numerator, number of deaths, over this larger denominator. And I think that when you look at, we now know that the case fatality ratio in Mexico is very close to what we see in U.S. and Canada. I believe the last estimates I saw was 3 to 5% in U.S. and Canada as a ratio, and Mexico, the last estimate I saw was 0.6%. So not that far off. And I think as we probably learn more, it'll even become closer. So that's my answer.
Too many people questions the attention that is being made to this type of influenza. Too many people argue that only in the U.S. usually influenza kills about 40,000 people in 1 year, and they believe the rate of this one is not so high. Why people must be concerned about this H1N1 virus?
That's a great question. I think that we need to be very careful that being predictable in its unpredictability. If this virus goes away, great. The response, we've learned a lot. It's been a test case for something that could be more serious in the future. A lot of lessons to be gained. But if it does change and become more severe, we are blessed by what we have and how we've responded to be better prepared. The question becomes that we do have other health priorities, and we cannot lose sight of that. We don't want to overreact and forget about the fact that HIV still kills people, or that diarrhea in children still kill people, that every hour 2 children die of invasive pneumococcal disease in Latin America and the Caribbean. So those are questions that we need to balance with our response to this, and there's no question about that. And I would say that it would also be important that when we take action, that we do so looking for the best opportunities to have a bigger bang for our effort, so that we're looking for opportunities to reach out. If we're supporting a lab in a country that otherwise has minimal resources, while we're there, we also try to support other lab surveillance for other diseases, and so that we expand our impact, and that over time I think will be very, very beneficial. The risk of overreacting, I think I've alluded to, but the risk of underreacting is the other side of the coin and could be very damaging if we do that. So it's that balance. It's the balance between, and on a day-to-day basis, remember that we do have other public health priorities and we can't forget about them.
In the case of Mexico, do you think Mexico overreacted or reacted with balance? Because too many people is now seeing that Mexico lost a big tourists and some other activities. I mean, the loss for Mexico was huge, and people is trying to find out if there was an overreaction or that needed to be that way.
I think all my colleagues here in the building, I think Dr. Mirta Rosas, the director, has said on a number of occasions in public that the reaction was appropriate. This is a new virus. It's never been seen before. It's never been circulating in humans. So we just don't know how it's going to respond. And what Mexico saw at that time was a number of deaths. And they took appropriate actions. They did so for the benefit of the world at the cost that you're mentioning.